indeed my privilege and honor to serve as your MC today. Protecting public health is one of the most important factors in COVID-19 economic recovery efforts. The healthcare industry is also one of the fastest growing sectors in the central Kentucky's economy. Given the importance of healthcare to Lexington's economic future, we wanted to spotlight this topic and feature leaders in the healthcare ecosystem for an in-depth discussion of COVID-19 impacts, trends in healthcare delivery, challenges and opportunities on the horizon, and updates on key areas such as research and development, telemedicine, mental health, COVID-19 vaccination development and distribution, and more. Before I introduce those leaders and begin the discussion, I'd like to take this opportunity to thank the sponsors of today's Spotlight. We appreciate their flexibility, support of the Chamber, and support of this event series, highlighting innovative topics for our community. All the event sponsors were displayed on your screen as you joined the call. We hope you'll consider doing business with them in the future. Without community-minded businesses like our sponsors today, we would not be able to provide you with the quality programming we've become known for. At this time, I'd like to recognize James Faraday, Chief Investment Officer with WealthSouth, for presenting sponsor remarks. James.
Thank you. Good morning, Bob, and thank you again for this opportunity to partner with Commerce Lexington. Again, my name is James Faraday. I head up the investment team here at WealthSouth in Lexington, right downtown. And I know we've been fortunate to be involved with several of these events over the last year or so. I know I attended one on the bourbon industry. I attended one on the entertainment industry out at Keeneland. But I think, this morning, perhaps this topic is probably most relevant to the broadest audience. I mean, I think from children to grandparents, I know we probably don't have any kids on this morning, but no one's gone untouched, right, through this pandemic. So we've all had to figure out work, remote access, remote schooling, shopping, and then receiving our healthcare. So that's changed as well. I've got young kids, just taking them to the pediatrician has changed, right? Drive up, call up, wait, so a lot of changes that we've seen. And I know at WealthSouth, we've had a lot of clients come to us and ask us, how's healthcare affecting our investments, our finances, and of course, just personally on a very personal level. So, when we're building financial plans for our clients, healthcare is one of those top areas that we look at. It's part of our plans, and it's one of the, before COVID, it was one of the most challenging topics to really navigate. And I think COVID's just added a layer of complexity. So very excited to hear the speakers this morning. We've got a really diverse group, like Bob said, across some of the major hospitals in Lexington and the county health department as well. So really interested to hear what they have to say. One more item before I jump off. We've got some exciting news at WealthSouth. We're actually moving buildings here next week. So if you see boxes in the background, that's what's going on in my office. But moving over to, you may have seen the sign go up, 106 West Vine Street. So we're right across from Jeff Ruby's. But more importantly, we're right next door to the Ethereal Brew Pub that just opened down there. So we've joked that's going to be conference room C for us as we make that move. So please, come see us in one of our conference rooms certainly when things calm down around COVID. But thank you again, Bob. We really appreciate it. Thanks to all the speakers. Look forward to it. Thank you.
Thank you, James. Thank you for your remarks, your sponsorship, and your longtime support. We do appreciate you.
Thanks.
Now I'd like to introduce our panel. Many, if not most of you, are household names at this point in time. Going back to February, who would ever have dreamed we would encounter in 2020 what we did? But you know what? Communities like ours that are strong, that are innovative and problem solvers, we figure out whatever the issue, the opportunity is, we take care of it. But you all have become household names, and for that, we're grateful for your leadership and your team's leadership. The panel we have today, I'd first like to start with Dr. Karen Hill. She's the Chief Operating Officer, Chief Nursing Officer at Baptist Health Lexington, and a former Commerce Lexington Board Chair. Thank you, Karen. Dr. Dan Goulson, Market Senior Vice President, Chief Medical Officer with CHI St. Joseph Health. Thank you, Dan. We're very honored to have you. Dr. Andrew Henderson, he's the CEO of Lexington Clinic. Andy, always glad to have you. Thank you.
Thank you.
Kevin Hall, he's the Communications Officer with the Lexington-Fayette County Health Department. Kevin, we see you an awful lot on TV. Good job, by the way. And Dr. Mark Newman, he's Executive Vice President for Health Affairs with UK Healthcare. So, all-star panel, let's just jump right into some questions here. And I'm going to ask the first question to Kevin. And I'm going to break this question up. It's a long one, so I'm going to break it up into two parts. The first part is, can you provide a brief overview of where the community stands as it relates to COVID-19? Can you address why we've seen spikes in cases in Lexington?
Yeah, great question. Thanks for having us to be, letting us be on here. As we've taken before, any questions that you have, I'm glad to answer this during this time today, because we understand there's a lot of confusion out there. And the best way to address that is to speak directly to the people of Lexington and Central Kentucky. And so we really appreciate this opportunity. The most recent numbers, they came in about an hour ago. They are through the end of yesterday. So the complete 24 hours of yesterday, Lexington has 10,194 confirmed COVID-19 cases since the outbreak began. That includes 118 new cases yesterday. We had seen a period of time where we were about 50 to 60, 70 new cases per day, but we're now starting to see that trending upward. The governor has mentioned over the last couple of days about the surge in Kentucky. We do not feel in Lexington we're calling it a surge just yet. If you look at September, that's when we had a surge. There was a spike where we were seeing 120, 130 new cases a day. But right now it is definitely trending upward. Before I forget, all of this information is posted daily on our website, lfchd.org. It includes charts and graphs so people can see these numbers. Some people are visual learners, and some people need to see those charts and graphs. And you can make your own determinations of where Lexington is. And it has demographics of all the cases as well. What we're seeing right now in Lexington too is, unlike September, when we were seeing that increase in cases, that was most likely due to colleges and universities coming back into campus. And I want to be clear, that's colleges and universities, plural. Obviously, UK has the lion's share of that because they're basically a city within the city. But it is unfair to say that it was only the University of Kentucky. All the colleges and universities in Lexington had students returning back to campus. And it's fantastic that they were doing the testing they were doing, because then it identifies positive cases, allows them to get into isolation to avoid spreading it to others. We've worked very closely with UK, Transy, BCTC, Sullivan, and all the other educational places to make sure that the information was out there and that we were working closely. What we're seeing now, though, is an increase in cases in long-term care facilities, and that's growing every day this month. That's troubling for two reasons. The first and the biggest reason that it's troubling is those are our most vulnerable, or some of our most vulnerable members of the community. Our older population are the people have had 85% of the deaths. So 65 and older have been 85% of the deaths, but only 9% of the total cases. So we're having it in the long-term care facilities, and they have had the vast majority of deaths have been in the long-term care facilities, have been connected to there. So this is troubling. It's also, as Dr. Humbaugh, our Commissioner of Health, likes to remind people, the residents aren't bringing those in. It's coming from outside. So whether it is visitors, whether it's employees, what we are learning is that people are not staying home when they're symptomatic. People think that, oh, this is just a cold or it's allergies, and they're going out into their workplace, or they're going out to visit people, they're going to gatherings. And we cannot stress that enough, that if you are sick, you need to stay home. This is not one of those cases of where we all just want to plow through it and go to work and and show the boss that we are, how hard we're working, because you could wind up spreading it to multiple people in an agency and cause a temporary shutdown of services. It's looking past the human cost of it as well. I think that wasn't quite so brief, but that's where we are with it.
Well, and part two, what are the most common questions being asked by residents, and what are the main misconceptions that people believe are that are true related to COVID-19? And you may have touched on this a little bit.
I could hit on the misconceptions for the full hour, so I won't go too deep into that. But what right now, the biggest one that we see is that this is no different from the flu. And this is absolutely different from the flu. We've said this all along, that it is more severe than the flu. We also, it's spreading more rapidly than the flu. Last year in Lexington, we only had around 700 lab confirmed cases of the flu. And I think it was 5 deaths. Now, I'm speaking with the other panelists here, these medical providers, they understand a lab confirmed test is just that. It's a medical office that's taken the sample and sent to the state lab. Many offices, if not the vast majority, don't do that step. They do the rapid testing inside, or they are able to diagnose, they see the symptoms and they're able to, it's the flu. So that's only a fraction of the flu cases each year. But even looking at taking that and growing it some, it doesn't compare to 10,000 cases and 90 deaths that we've seen with COVID-19. Also with the flu, it's been around for years and years and years and years. We've studied the flu. People know what the long-term impact of influenza is. We do not know what the long-term impact of COVID-19 is. You see reports about otherwise healthy adults. I'm talking professional athletes who've had to retire unexpectedly because of heart and lung issues after contracting COVID-19. So these are the people who have conceivably the peak health and access to some of the best healthcare in the country, and that's some of the impact they're having. So COVID-19 is not just get sick and get better or get sick and die. There's so much area in between that we simply don't know yet, and we don't want people to find out the hard way what that impact is. So that's the biggest misconception that we deal with right now, is that you get it, it's not a big deal, and you go back and you're 100%. That's a huge misconception, and could be one that is very, very maybe not fatal, but could have major health impacts down the road.
Wow, Kevin, you hit exactly what I hear out on the street too, that how people have tried to sort this out. Well, let's jump in now with our hospital executives. We're going to start with Karen, then go to Dan, Mark, and Kevin on this first question. Hospital capacity and availability of PPE were issues of concern for many in the community at the beginning of the pandemic. Can you provide an update about how your organization has adapted to deal with the impacts of COVID-19? And where are you currently with PPE, bed capacity, and the ability to offer other vital services? And finally, are you worried about the surge of COVID-19 cases during the winter months? So I know packed in a lot of questions. And I can break that up if I need to, but Karen, can you start us off?
Yeah, and I think I can remember all the questions, so let me give it a try. With PPE, I think one thing that the public has figured out, and one of the interesting things in the pandemic is people are becoming more informed about healthcare issues because they're having it in their face all the time, on the media and in the news and print. But the PPE recommendations from CDC have been evolving since this started. In the beginning, I think there was even some confusion, as you've heard people say, about, whether certain kinds of masks were effective, was a mask effective at all, and that kind of thing. As those have evolved, I think the hospitals, and I know in Lexington, because we talk a lot and try to collaborate, have done a good job trying to respond to that. Part of the issue in the very beginning is that a lot of the supply for Baptist Health, for example, and we have 9 hospitals in Kentucky, and 8 and 1 in Indiana, our supplies were from China or from other markets. About the time we started needing to increase our inventory, which would have normally been something that would be not too complicated, we started having competition for that inventory from other parts of the world. In addition to that, about that same time, the weather impacted another supplier that we used in the Gulf. And so that also hurt our supply a little. At this time and in the last few months, Baptist has been able to move supplies between the hospitals to get extra inventory from other vendors. And right now we don't have any issues with PPE. We still watch it very closely because we want to be prudent with our supplies. We want to make sure we have enough in case there's increased cases, and we want to protect our staff. One example of a recommendation that's changed that we implemented about 2 months ago is we now have all of our clinical.
We may have lost Karen there. Karen, can you hear us? While we're reconnecting with Karen, Dan, we'll go to you. Oh, there's Karen. There she is. She's back. Oh.
Yeah, sorry.
There you are.
I think it was a call that was interfering. But anyway, we wear eye protection now. So if you come to Baptist, another thing that we've done, Bob, and this is a little different for us, we've asked the patients to wear a mask in the room. Our doctors, our nurses, our housekeepers, that mask is effective to protect them. And we have asked all of the patients to also wear a mask in the room. So that's something we're doing. On the issue of capacity, one thing I want to bring up is that capacity in a hospital is a changing target. One day we may have a very busy emergency room. The next day the ER may be a little slower. One day our surgery schedule may be a little busier, and patients may have cases or procedures where they need to stay a couple of days. The next day, the mix of those patients may be different, and a lot of those patients go home either the same day or the day after. That's a tough question. Baptist is a busy hospital. Yesterday, for example, we had 10 open ICU beds. Today, I think the numbers are less because there are some patients that were admitted. Sorry. I have to tell you the hospital's calling, but I can ignore them for an hour. But one of the things that we have tried to do is collaborate with the referring facilities who want to send us patients so that we can make sure that we have beds available when we need to have those beds. We work with our smaller hospitals like Richmond and Corbin, for example, and we have tried to make sure that we help provide them infectious disease expertise. Sometimes the patients don't need to come to us. Those smaller markets don't have the doctors to take care of those patients. And so we are using telemedicine and some other approaches to help with that. And the last question is, yes, I'm very concerned about increases in the fall and in the winter. We had our first patient with COVID and the flu about a month ago. And so that was even before a lot of people started taking flu vaccines, and we are very worried. We are encouraging people to take the flu vaccine. If you're over 50, you should consider a pneumonia vaccine. And we are encouraging everybody to continue to really be vigilant about wearing a mask and washing your hands, because those things can help prevent the flu, confusion with COVID, infections from COVID, and to protect them from winter ailments that may bring them in the hospital and cause issues with census that could keep other patients from being able to get in. We are able to see patients for normal procedures. And one thing that we have really enjoyed is that we're still having a lot of babies during COVID. You know, things just happen, and families are having wonderful occasions, and people have to have surgery, and they need to have heart cath procedures. They have cancer, and we're able to take care of those patients. But the care has changed, and people are very careful. They have to wear masks in those areas. We do extra precautions like decreasing people from the waiting rooms. We're not letting people sit in waiting rooms and congregate. But yeah, we are able to still take care of patients. We want them to be healthy, and we want them to take advantage of healthcare services to stay healthy.
Yeah. Thank you, Karen. Dan.
Thank you, Bob. At St. Joseph, we have a lot of the same concerns that Karen just went over and same challenges. And I would say that the PPE situation, just to discuss that for a moment, and the challenges that we had early on, really is just a supply chain issue. The demand went up dramatically and quickly in the early days of the pandemic, and it's taken a while for suppliers to be able to catch back up with that. We are in a good position now and are fortunate to be a part of a large nationwide health system called Common Spirit Health, with about 140 hospitals throughout the country. And so we're able to tap into the purchasing power of our parent organization, which helps things pretty significantly. Matter of fact, our parent company has actually bought equity interest into a PPE manufacturer so that we can guarantee our supply chain. So what that has resulted in for us is we've moved from a kind of an uncomfortable situation early on with PPE availability to really being able to build up our stores now, and we have plenty of PPE that is available. Another similar issue that wasn't a part of your question, but I think fits right in, is testing supplies, because that also has been a challenge over these past several months, and has a very significant supply chain feature in that as well. So manufacturers of various testing platforms and testing supplies have now caught up in their production, and we find ourselves in a situation where we are able to be a little bit more, not have to be as constrained in the testing that we make available. I think as a country we still aren't quite there in terms of our testing situation. Kudos to local government though, because there is public testing that's available, and you know, in talking with my son who currently lives in Denver, and in a metro area where you would think that resources like that would be available, we're much better off in Lexington for public testing availability than he is in Denver. So congratulations to everyone on that front.
Wow, good point. Dr. Henderson.
Thank you, Bob. As a non-hospital, I'll give you a few perspectives that I see on all of this and what's going on. I can't echo stronger what Kevin had to say about misinformation. A few examples, real life examples. Last week, we had a patient come in for their scheduled colonoscopy. They have been through the prep, which is the hard part. They refused to put a mask on in pre-op. We gave them a mask, encouraged them to use a mask. He refused, so we declined his care. He went out with profanity, screaming, hollering, this is all a hoax, this is fake. We hear from other institutions that you all represent that you've had similar situations, including a patient who went out knocking down chairs and tables and so forth. I went to vote last week at Tates Creek Public Library. I think it was 3 days into voting. I had my mask on. The lady in front of me waiting outside was wound up screaming, this is all a hoax, we should all take these masks off. I stood 15 feet away from her, not 6 feet, to follow her in. Nobody from the polling folks would try to quiet her down, but you could hear her throughout the whole line that she knew a doctor at Cleveland Clinic and this is fake, and she used to work for state government. This morning, my wife is telling me on social media, which I refuse to participate in, the number of people who continue to say this is fake and a hoax and it'll be gone in 2 weeks after the election. This is real. It is killing people. Let me give you my quick little story. Being the most seasoned and experienced panelist, i.e. I was born before the rest of you, I moved here in 1981 to practice medicine. I have been an internist since actually finishing training in '79. In the early '80s, HIV/AIDS appeared on our horizon and a challenge. In the early '80s, there was terror. Surgeons wouldn't operate unless the patient had the test first. We then evolved into universal precautions that everybody is a potential patient, and a few messages. The peak death rates did not occur until the mid-90s. And folks, if you look it up, 95, 96, there were 40 to 50,000 deaths a year from HIV/AIDS in the mid-90s. We have now hit 250,000 in the US this year. Number two, we're almost 40 years into HIV. We don't have a vaccine. So putting the hopes into a vaccine, to me, are unwarranted. It's basics, it's misinformation, it's disinformation, and it's basics. Wear your mask. I don't want to breathe the air you just blew out, and you don't want to breathe my air. And it's stick to basics. My daughter teaches public health at Jefferson University in Philadelphia, and she sent me a nice sign they have that says, "Masks mean business." So for the business community, to hope that the vaccine is going to solve this or there's going to be a new treatment or cure. I think that's false hopes at this point. And wear your mask, follow the basics. You're right. We don't know all the long-term consequences, but we've got people dying all over the place. Wear your mask, but from the clinic point of view, we're like everybody else, we've adapted to this, but unfortunately, we all have to deal with patients who come in with that horrible misinformation. As Karen mentioned, we require patients to wear masks. Waiting people that come, families sit out in their cars, don't get back to waiting rooms. We've gotten COVID fatigue, and unfortunately, that's why the numbers are up, and that's why people are dying.
All right, thank you.
Thank you.
Thank you, Andy. Mark, let's come back around to the PPE question again here, especially as your size here in the community. So regarding PPE, where you're at today, and then also getting into bed capacity and the ability of to offer other vital services.
Thanks, Bob.
And then also, if you will,
reiterate a lot of things that Karen and Dan have said, and again, part of the thing, we were lucky as far as PPE because we had decided and had and built up a local warehouse, so we had some capacity and other issues that gave us time. Because I think to Dan's point, it was a flow issue and demand created all at once and hard for the supply to keep up with it. So I think from that standpoint, but we're very good in a very good place. And I think we're working with our colleagues well to understand and keep that well across the city and across the state. I think the second thing as far as capacity, I mean, we're seeing, a typical, I think we're all reasonably busy in the city, but we all have substantial surge capacity. And I think that's the reassurance is that, the neat thing for me, and I don't get credit for it because it was built before I got here, but our Pavilion A is built to have all the beds moved to ICU beds, all of them be able to move to negative pressure, and all of them to be able to ventilate 2 patients at once in each ICU room. So we have a substantial capacity to grow if we need to. Now, the hope is we won't get there, but I think that's what we want to be able to do is a surge capacity. And I think the last 2 things, I do think that the health systems cooperating together are the best ones to help make some of the decisions around our ability to manage that capacity and have patients flow, because the idea of kind of trying to shut down all of healthcare, we're still recovering from the shutdown before. Our case mix index, which is the complexity of the patients we're seeing, is the highest we've ever seen. And a lot of that is because patients were avoiding the hospital or avoiding necessary care. And if I could make any comment to the community with their own staff and their own people, again, we need to make sure that the things to keep people healthy that we do on a routine basis, we continue to do. The hospitals, to Karen and Dan's point, are a very safe place. We've done our own studies looking at the COVID antibody levels of our staff, which is an indication of who's been infected. And when we see that, it's about 1.25%, which is about half of what you see in the general population now. It is a safe place to come and be taken care of. And I just want to reiterate that for the people listening, because we're ready if we have a surge, and we are worried about it, okay? But we're ready to cooperate and work together if we have a surge. But I think that patients need to seek care when they need it and not delay, because we see a lot of people waiting still, and by the time they get to us, they're very sick. And I just want to bring that out as a key thing for health in general. It's substantially impacting health in the community.
Thank you. And I have to tell you, we had a firsthand view here at Commerce Lexington when we were also trying to reach out to all of you early on to see how we could help in that supply chain network of PPE. I'm here to tell you, we were so impressed with how everyone in one of the most difficult moments of time were working together. And again, that again speaks very well of each of you and your leadership. Let me move on to the next question. Kevin, has the main role of the health department evolved since the beginning of the pandemic? And what do you expect your main concerns with COVID-19 to be as we head into the new year?
Great questions. We really have a couple of different primary responsibilities. One, and I guess this is somewhat selfishly speaking, since I do the communications here, but as a department as a whole, our job is to provide good, factual information and prompt information to the community. That one of the biggest problems with the COVID-19 response has been at the federal level, there has been misinformation, there has been inconsistencies, and from the state and local level, we have tried to, even if it's not been great news, if it's been something that even reflects poorly on us, we tackle it head on, because we understand that there's such distrust in the numbers, and there are people who unfortunately believe it is a hoax, and that's been fostered from people who we wish would know better. And so knowing that, just being accountable, that if there has been a problem, letting people know here's what happened and here's how it gets resolved. But also that to clarify any confusion that comes out from the CDC, or to let people know that this is what is really happening, this is what the numbers mean. And also to remind people that 10,000 cases and 90 deaths are numbers, but those are humans behind each of those. That it's easy to get bogged down into the data, but every person every case that we report on, it is a real living human that means something to someone that is affected by it. We also, another piece that we're really responsible for is bringing organizations together. Before this call formally started, I was talking with the other panelists that I made a comment yesterday to the mayor that you don't realize how many community partners you work with until a crisis like this hits. And another panelist said, well, that's just Lexington. And that's exactly right. I've seen some of the worst of Lexington in some of the comments, and there's been a person yelling at all of you. I've had people yell at you about this is a hoax. They refuse to do this, but I've also seen the best of Lexington as well. And if I can just real quickly just tell a brief story, we have at-home testing available. We early on when the testing was rolling out, we heard from people that you need to have something in place for people who can't get to the test sites. The health department is not responsible for the overall testing at BCTC and other places, but we have worked to be able to provide at-home test kits to people. And very early on, we were telling people that you need to call, there's prioritization to make sure that we had a limited number of tests. And we learned that people said, well, I was going to call on Tuesday, but I didn't really feel like I needed it, and somebody needed it more than I do. And that was a very common thing that we heard. And so we changed our wording because we didn't want anyone, if you need a test, you need a test. We don't want that to be the reason that trying to put someone else's needs ahead of it. And I tell that because it is easy for us to get bogged down into the negativity that comes on social media, the negativity that you hear from the patients who want to yell at you, but there are still some great people doing great work. So we are trying to connect all those different people who are doing the work. We are in constant contact with so many organizations who are trying to make sure that nobody slips through the cracks on this. And that is a big piece of what we're doing.
So going into 2021, Kevin, what would be your biggest concern?
The combination of flu and COVID-19, we get pretty frequently. I get asked from reporters, is it possible to get the flu and COVID-19 at the same time? As you heard just moments ago, it can happen. It's rare, likely, but it can happen. It's happened here in Lexington, as we heard. But even separately, there are two very serious illnesses, and having the potential for a flu outbreak during a worldwide pandemic is frightening. Also, the COVID fatigue and burnout is absolutely real. And I always tell people on the non-medical side of it, if you think you're tired of COVID-19, talk to a nurse, talk to a physician, talk to a public health employee, talk to anybody working this response who's working 12, 13, 14, 15-hour days, 7 days a week. Nobody is more tired of it than we are, but we're not stopping because we can't stop. And that's my concern, is that people are going to just brush it off. They're going to get tired of it and realize that, and think they don't have to follow the guidelines.
Okay, I'm going to move in. This is going to be a question for everybody, and we're going to need to kind of tighten our response times because we've got several more questions here. But so far, great information. This is excellent. So this goes to all of you, and we're going to start with Dan. But can you share your insight on the status of effective COVID-19 medical therapies and vaccine development, both of which are critical to our economic recovery? And then when a vaccine is approved, how can we expect the distribution process to be handled locally? And what will each of your organizations play in this process?
Sure, Bob, thanks. We're in a challenging spot as far as therapy goes because we don't have a definitive therapy. So we have a couple of options that make the disease better, but we don't have a cure and don't really see a cure on the horizon. There are a couple of medications that can help kind of lessen the intensity of the disease, and one of those is an antiviral called remdesivir. That medication was available on essentially an experimental basis for a period of time early on, and it's more widely available now. And so we're using that medication for patients that are in the hospital, as I'm sure everyone is. We've seen that that shortens the course of the disease, and people tend to not get as sick with the disease. It doesn't make them healthy immediately, but it certainly makes a difference. There's another medication that's a steroid called dexamethasone that is widely available, but that has helped mute some of the inflammatory response, and there's been advantages there. And then the last category is of medication that comes to my mind is in the category of antibodies. So the first way that we were able to deliver and administer antibodies back to patients to help a patient's immune system fight the disease itself was through the blood and the plasma of people who had the disease, built up their own antibodies, and then that could essentially be harvested from the donated plasma from those individual patients. And so the term convalescent plasma was coined. And we worked in collaboration with the Central Kentucky Blood Center to have convalescent plasma available to give back to our patients. And so have done that as well as the other hospitals in town. So all of those things together in various combinations have made the disease more manageable. The survivability in our experience has gone up. Not as many patients need to go to the intensive care unit. Not as many patients need to be put on a ventilator but because of these therapies that we've had. But getting to the day of having a definitive cure will certainly be a great thing. But as Dr. Henderson kind of alluded to as far as the timeline goes, I don't think we should hang our hat on that going forward for the time being. The vaccine development is primarily being handled through pharmaceutical companies. Dr. Newman may have some specific comment about that because UK, along with Baptist, are participating in one of the studies, I believe, with one of the available vaccines. And there's planning that's going on in terms of vaccine delivery once it does become available. That planning is happening on the federal, the state, and now on the local level. And we expect that hospitals are going to be a part of the vaccination plan, especially early on when limited availability is going to be the rule. And the prioritization that has come down from the federal government that frankly I think many probably would agree with is that the first vaccine should be to the highest risk segment of the population, and that's frontline healthcare workers. And so hospitals will have a role in immunizing essentially their own employees, but other healthcare workers as well. And so we're working through a lot of preparation for when that vaccine does actually become available. And I think that we're in good shape for that.
Yeah. Dr. Henderson.
When you look at healthcare, as a general rule, most of us are healthy, though obviously children are born with genetic defects, and I don't mean to minimize that. But as a general rule, we're healthy, and our job in healthcare is to keep you healthy, to prevent illness, if you have illness, to help you through the illness, and if it's a terminal, to provide the support and comfort. As Dr. Goulson pointed out, we don't have a definitive treatment. Our goal is to prevent this disease. It's interesting, I just read a couple of studies last week out of Europe identifying specific genetic defects that we may have that make an individual, why does one person who's 40 die from this and the next person barely gets sick or doesn't get sick? It appears to be genetic differences in the individual who is exposed to the virus. Now, even if we tested it, we can say who's the high risk, it's still out there and somebody's going to get exposed. We do know the older you are, the more comorbidities, the color of your skin all can affect how you respond to what's going on. We should treat everybody in a way to try to prevent this infection. I agree. I do not think a wonder drug therapeutic is on the immediate horizon, nor do I believe a vaccine is on the immediate horizon. We must prevent this disease. Wear your mask.
All right. Dr. Newman.
I'll agree with our prevention is our best treatment by far. The other thing I will say is that the drugs that Dr. Goulson talked about, dexamethasone, remdesivir, other antibodies, they work much better early. And so from that aspect, coming in, just want to reiterate, if you're concerned, come in, be assessed. Once we don't prevent, then we have to treat as effectively as we can. If we can intervene early, we have a much better opportunity to be able to make a difference. So I think that's a key as we go forward. I will say we are in the middle of vaccine trials. I'm a little more hopeful than Dr. Henderson that we'll get somewhere by late January or February with one of the 4. But again, we've already lost one of the 5 vaccines is not going forward, and we've had some issues and concerns with safety on some. So I think that, I'm hopeful in the late January, February timeframe, we may get to a vaccine, but I think, and I think we will start, to Dr. Goulson's point, by giving it to probably the people that are exposed the most or that are the highest risk for negative effects. But they're also the ones that you have the biggest concern probably around the safety of the vaccine. So to Andy's point from that, I think I'm hopeful, and we wouldn't be enrolling 1,000 patients in this trial if we weren't hopeful that we would get to a good result. So I think those are my point, but I think we've got a lot of water to get under the bridge before we're there. And so prevention and taking this seriously is going to continue to be key.
Very good. Dr. Hill?
Mine's going to be quick because they've really covered everything. And I think one point I want to make is there are no advances that are not available in Lexington. And I hope that gives the audience some reassurance. I'm very proud that our healthcare community is advanced in every way, and that private hospitals and the academic medical center are able to take advantage of anything you could get in any market. And it's interesting, one of our first ICU patients was a woman who flew from New York to take care of a relative here that had recovered from a surgery, and she came 24 hours after that, was put on a ventilator. She received the first, and Dr. Fox, who's well known now, he's done a lot of stories, received the second dose of plasma that we had. Her husband came to drive her home when she was discharged, and he said if she'd been in a hospital in New York, she'd have died. And we appreciated the fact that they recognized that she got the best care that she could have gotten. And so I think that should be a comfort. I think that people need to be careful if they have a relative that's in home with them with COVID, and there are some guidelines on the CDC website that they should look at, because you can very easily contaminate your relatives, and nobody wants to do that in any way. And so I would recommend that people look at that, because the chances are you're going to have a relative that's got it sometime in this year if you haven't already had that. And the third thing that I would tell you is that I think that we are setting people up for disappointment if they think that they're going to get to stop wearing a mask sometime this winter. I think they will be wearing a mask, and I think there will be social distancing until probably summer of next year, because as they've talked about the vaccine trials and the immediate distribution, it will take a long time to get enough for people to all feel comfortable to take off the mask and to start not worrying about social distancing. And so I want to set a realistic expectation for people that I think we're going to be dealing with the community expectations of distancing and mask and hand washing until next summer at least.
Kevin? Thank you, Karen. Kevin?
Everything they said, that is fantastic. I think that realistic expectations is something that is worth repeating, because I think too many people thought at the beginning of this, there's a flu season. We're used to having a flu season of 6 months. They thought that this would be a COVID season, and unfortunately that's not the case. So listening to the experts, and we have, Lexington has some of the finest medical providers of anywhere in the world, and I would encourage people to listen to what these experts are saying.
Okay. I know a couple of you I heard are participating in the, your research institutes are participating in some of the different tests, the trials. So anything there to kind of add or share that you think would be particularly helpful?
All I'll say is that, first off, I want to thank our colleagues at Baptist and Norton's and Jewish for, continuing to work with us and participate. But there's a lot of, to the points that have been made, these trial sizes total are around 30,000 patients. They take a fair amount of time to get to the right place, and there's a lot of water under the bridge. And then we'd have to distribute that. So I think Karen's point is a good one. Even if we have a vaccine in February, it's going to take a good while. The other issue that we're going to have in the community is trust. We just heard about it. We have a lot of people that don't either trust healthcare now, whether that's around the healthcare disparities issue or other things. And so getting them to accept the safety and other things as we go forward is going to be a key thing that we're going to have to work together on.
Okay.
I think one thing that I appreciate is an example of the partnerships between the academic hospitals and the community hospitals in letting Baptist participate with this research. I think the initial announcements and more will come, but people just need to watch for things as they develop, because everything is always going to be handled in the safest way possible. And I think we're all going to learn a lot about research through all of this, because I know even the public now is hearing about studies that start and stop and things that are reportable as a patient experiences side effects. A lot of public community people wouldn't have paid attention to or even heard about. I think it will be good for people to learn through this process about the research process so that they can feel more confident as they take a vaccine.
Very good. We're getting a little short on time. I'm going to jump to the next question. And this is to everybody. From mental health issues to telemedicine and planning for a future pandemic, how is healthcare as an industry innovating to meet the challenges on the horizon for public health? And let's start with Dr. Newman.
I'll be quick. I think on the mental health side, I think we're realizing the significance of mental health in the broader aspects of health in general and what this has done for people. I will say telehealth and its expansion for telepsychiatry is huge. Probably now 80% of our psychiatry is being done from a telemedicine standpoint, so we can expand that capability more broadly across the state and the access. So I think that's key. And I think also we talked about telemedicine in general, but now we have EICU and things like that. So we can be supporting other hospitals to have people stay in their ICU or stay local, and then only have to come if they truly, truly need to come. And I think those are some of the technology, and we've been able to accelerate that much faster than we probably would have if it hadn't been. If there's a silver lining, it may be some of the advancements that we've made because of that. So I'm hopeful.
Karen?
I'll be quick. I worry on two fronts. One is I worry about the healthcare workers because they're tired. They see good and bad always, but this has been accentuated. And so we're trying to do as many things as we can as an employer to help boost their morale and tell them thank you. And I think it's good if the community and knows a healthcare worker, a physician, a housekeeper, if they could tell them thank you, I think that would be appreciated. Just like I try to tell the people at the grocery store when I go, how much I appreciate them being there. I think the second thing is we have definitely seen an increase in patients who, in our hospital, we don't have psych, but we do have psychiatrists available. But we've seen patients with medical conditions who have psychiatric conditions or alcohol or drug dependencies on a higher scale, more admitted. I think if you have a family member or someone in your family that has a tendency for depression or has a history of alcohol or drug abuse, you should pay more attention to them because they may not be able to tap into their normal support groups or other mechanisms, but they need support. And I think anything that families can do to help support those people and try to keep them out of institutions and hospitals and those things through this so they can get back to their normal support groups and other mechanisms would be helpful.
Very good. Dan, Dr. Goulson.
Yeah, we all did a pretty remarkable pivot early on in the pandemic toward telemedicine, and the technology had been there, but there were some barriers that had been in place in terms of being able to be reimbursed for it. So some of those rules were changed. It made it more economically feasible. The technology was there, and so they all kind of converged quickly, and we moved toward telemedicine. And that's a platform that works great in many instances. It's difficult to use it in instances where you really need to be hands-on. It certainly is challenging that there's a physical separation between the two parties. But I think telemedicine is probably here to stay in some form or another, and we welcome that. So it was an innovation that was poised to explode. It certainly did, and I see us continuing that as we go forward.
Dr. Henderson.
My comment, I think we all keep thinking we want life to go back the way it used to be. Not just healthcare, but everybody. We have to adapt, and we are adapting, and we have to adjust to it, and we have to have realistic expectations, but it's not going to go back, and at least not in the near future or the medium future. We have to adapt and adjust. So yes, telehealth has been very helpful. I had one of my physicians the other day who's now doing many of his telehealth visits at 8 or 9 in the evening when the daughter can come by to mom's house has the iPhone because the elderly lady doesn't know how to work and do all of this. So he's actually at home doing calls. So that's great. We have that connectivity with the patient, but that's here to stay. The mental health consequences, I don't think we really just kind of seeing the tip of the iceberg. I believe the human spirit craves connectivity and relationships. And I know all of you on this panel, I'd love to be sitting at the table where we could smile and say hello and shake hands and so forth. We miss that. I think it's harmful to all of us. We need to be aware of it. We need to focus and do what we can to overcome it. But it's here to stay.
Yeah. Kevin?
Yeah, there's very little that I can add other than to say that, the governor likes to say we're all together, and that is true, but to always remember that it affects each of us in different ways, that your own experiences will affect how you each day with this, and not everyone has the same access that others do. But the one thing that we can all remember is that we're not in this alone, that if you are struggling, no matter who you are, there is nothing wrong with picking up the phone and talking to someone, whether it's your friend, a family member, or a professional. And Lexington has a wealth of people who can help with that.
All right, here we are on our last question. A strong healthcare sector is one of the reasons Lexington typically recovers from economic downturns quicker than most other cities. What can the business community do to help further support your institutions and the overall healthcare sector in Central Kentucky? And let's start with Kevin.
From the public health end, reach out to us if you have questions. We have a COVID hotline, 859-899-2222. You can email any of us, you can email me directly. We have an LSCHD website, and share our information. The more that you can do to be a conduit to your employees, to your coworkers, and to your colleagues, the better off we all will be.
Karen?
I think to continue to be vigilant with masking. I think people need to be reminded. Sometimes I find myself having to remind people about social distancing and masking. If businesses can do that and not take it for granted just because you happen to like each other and work in an office that you're safe, you're not. And so I think that would be helpful because it keeps people out of the hospital so we can help continue to take care of patients. So if anything, I think it would be being bold enough in a nice way to remind people of the social distancing and the masking to protect you and others.
Dan?
I would remind the business community to be sympathetic with us, just like we need to be sympathetic with you, that this has been challenging financially for our industry. And even though federal bailout money helped, when revenue gets impacted and you have the same fixed expenses, it's just a really financially challenging time that we haven't completely recovered from yet. So even though we're busy, I wouldn't say that we've hit smooth waters yet financially. And you know, as much as we want to say that we're here for patients' health, we're also happy when the business comes in the door too, so that we can keep our organizations going.
Very good. Dr. Henderson?
Would comment, one of the initial pushes to the business community was let people work at home. In fact, not just let them, push them to work at home. We basically moved most of our business office coders and so forth to work at home. In spite of our fears, their productivity is better at home than it was in office. Where somebody can work at home, let them do it. Help them encourage, create the connectivity, adapt. Obviously, we've had to change. In fact, with my leadership meeting this afternoon, we're going to talk about where do you pick up most food? What's your favorite pickup spot for food for carry out? A little bit of team building because we don't get to see each other, but learn and share for the business community. Wear your mask. We're with you. You're with us. We're all in this together.
Dr. Newman?
I'll reiterate Andy's point he just made. I think we're here for Lexington. We're here for you guys. If you have questions, reach out to us. And we're ready to do the things we need to do to take care of this community. But again, the more we can do, the more you can do to help us keep the community healthy, the better we'll be as we come through this together.
Well, on behalf of Commerce Lexington, I want to thank you all for taking the time. I found myself getting confused calling you doctor this or that or your first name, but you are so much a part of the community, and we all see you as just kind of one of us. But I got to tell you, once again, you've kind of scared me a little bit in a good way. I do, Dr. Henderson, I've been wanting to become, so I want normalcy back. And I have started cutting corners here and cutting corners there because I thought I was safe enough to do that, brave enough, or maybe just a little bit too ignorant sometimes on some of the right things. But this has been a terrific discussion to be continued. And as you have information, please let us know. We're more than happy to push that out throughout the community. So I want to thank our panelists. I hope that if there's a way we can help show your teams, your medical teams, how much we do care and do respect. I hear it all the time from folks. We know how grateful we are. And so thank you. Thank you to our sponsors, our presenting sponsor, WealthSouth, and finally to all of our Zoom participants. We appreciate your investment in Lexington. Thank you all very much. Have a great day.
Thank you.
Bye, everybody.